us this afternoon. We have a wonderful presentation in store for you with a guest speaker. My name is Kayla Rogers, and I am an Education and Outreach Coordinator for the Women's Fund. So before we get started, for those of you who may not be very familiar with the Women's Fund, we are a nonprofit organization that serves Houston area women and girls by providing them with the tools they need to be advocates for their health. We do this through focused seminars like today's class, curriculum-based classes, as well as with our publications. All of our publications are completely free, and you can download PDF versions from our website, thewomensfund.org. Or you can also visit our website to put in a request for physical copies of our publications. Today, also before we get started, I do want to keep some housekeeping things in mind. Please keep yourselves on mute throughout the presentation so that we can limit any distractions. If you do have any questions at any point during the presentation, go ahead and add those into the chat, and we will have a Q&A at the end. So today's presentation is over human papillomavirus with Dr. Kathleen Schmeler. And Dr. Kathleen is a professor of gynecologic oncology and the director of global oncology at the University of Texas MD Anderson Cancer Center. She provides care to women with gynecologic malignancies, including surgery, chemotherapy, and preventative services. Kathleen is also director of the colposcopy clinics, where she treats women with HPV-related cervical, vulvar, and vaginal diseases. Kathleen received her medical degree from the Medical College of Pennsylvania Hahnemann University School of Medicine in Philadelphia. She completed her residency in obstetrics and gynecology at Brown University's Women and Infants Hospital of Rhode Island. She came to MD Anderson in 2004 as a fellow in gynecologic oncology and joined the faculty in 2007. Her research interest is in cervical cancer prevention and treatment and HPV vaccination, particularly for resource-constrained countries and medically underserved women in the US. Kathleen has authored and co-authored numerous articles in peer-reviewed journals. She is an active speaker both nationally and internationally. And so we are so very fortunate to have her here today to give this wonderful presentation. I'm going to go ahead and turn it over to her now so that she can go ahead and share her screen.
Can you see my slides?
We cannot see your slides.
Everyone, it's really a huge honor for me to speak with you today. As Kayla said, I'm a GYN oncologist at MD Anderson, and I feel very, very passionate about HPV vaccination and preventing cervical cancer. And the reason for that is that my day job is to take care of women who have either pre-cancer of the cervix or invasive cervical cancer. And obviously people suffer a lot from this, and unfortunately many people die of this disease, and it's completely preventable with the tools that we currently have. So Meredith and Monica and others who are on the call know that whenever they ask if they can do something for me, I always say, please tell people to get their kids vaccinated against HPV, and I'll show you why in this talk. Please feel free to interrupt me at any point if you have any questions, and certainly I'm happy to take questions at the end as well. But I want to talk a little bit about the human papillomavirus, the vaccine that we have against the human papillomavirus. And then if there's a little bit of time at the end, I'm just going to talk a little bit about the work that our group does related to cervical cancer prevention and treatment, both in Texas and globally in other countries. So HPV, or the human papillomavirus, is the most common sexually transmitted infection. The initial infection usually occurs as a teenager or a young adult. And most people clear it and never even know that they had it. 80% of people have HPV at some point in their life. So we say it's like the common cold of the cervix. Almost everybody gets it, but for most people, it's not a problem at all. There are 79 million Americans who are currently infected. There are about 14 million new infections every year in the US. And as I said, most people never ever know that they're infected. Less than 5% of people will go on to develop significant pre-cancer, and less than 1% will develop cancer. So how you have to think about it is that for some cancers, and I'll go over that, you need to have HPV to have cancer. But if you have HPV, it doesn't mean that you'll get cancer. In fact, there's less than a 1% chance, but it is the cause of several types of cancers. Frozen, hold on. So you can see here, these are the types of cancers that HPV is associated with. So the one that most people know about is cervical cancer. Obviously that occurs only in women. And essentially every case of cervical cancer is associated with HPV. It's more than 99%. And what we've learned in the last few years is also many cases of anal cancer. Many of you may have seen Farrah Fawcett was a big spokesperson for anal cancer, but that's also an HPV-related disease. 70% of head and neck cancers are throat cancers, and this is primarily in men, are HPV-related. 65% of vaginal cancers, 50% of vulvar cancers, and 35% of penile cancers. So several cancers are associated with this virus. The good news is we have great prophylactic vaccines against HPV. And these became commercially available in 2006, so we're at 14 years now. And they're designed to prevent infection and therefore the cancers that can develop from the infection. The most important thing about these vaccines is that they work best if they're given before the initiation of sexual activity. So in HPV naive boys and girls, and I'll talk a little more about that. They don't work if people have already been infected with HPV. There are many types of HPV, so they work against some other types, but the most important thing to remember is these vaccines really work best if they're given to young kids before they become sexually active. So the recommended age is 11 or 12, but it can be given as early as 9. As I said, it's ideally given before the onset of sexual activity. You can give what we call catch-up vaccination up to age 26. And now the vaccines are actually approved up to age 45. And again, these are recommended for both girls and boys. And I'll go over a little bit more about that. This was big news last year when the vaccine got expanded for people aged 27 to 45. And the thought there was that most people by the age of 27 have already been infected with HPV. In fact, 80% of people. But it could provide some protection against some of the different HPV strains or types that they hadn't been exposed to yet. So it's FDA approved for people up to age 45, but the CDC and the folks who make our national recommendations about vaccination don't fully recommend it in this group, but they say it's a sort of a shared decision-making between patient and provider. So essentially that's saying it doesn't hurt, but it may not help, so you and your doctor can decide. Again, the reason to give it after age 26, or some of the things associated with it are that it has decreased effectiveness because you've probably already been exposed. It's not very cost effective, so that's why it's hard for governments to really push it, and it's not covered by most insurers because of that. And it's about $150 to $200 per injection. We also have a worldwide shortage of the HPV vaccine, and we worry, obviously, or we all know that it's because once we have a COVID vaccine available, which will be terrific, that that will sort of take away a lot of the manufacturing from other vaccines. So now's the time to get it. The immunization schedule is if you vaccinate before age 15, and again, the recommended age is 11 to 12, you only need 2 doses, and they are 6 to 12 months apart. At age 15 or older, and if your child's immunocompromised, so if they have HIV, cancer, organ transplant, then we actually do 3 doses. We do 1 dose and then a second dose 1 to 2 months later, and then a third dose at 6 months. And there are lots of studies going on right now to see if we can actually just give 1 dose. When it first came out, we were giving 3 doses to everyone, and then we figured out that you actually were good with 2 doses if you were under 15 and not immunosuppressed. And now we're trying to see if we could just give 1 dose, which obviously would simplify things a lot. Why vaccinate boys? You know, when the vaccine came out, it was really targeted towards cervical cancer. But what we know now is that there are many HPV-related cancers that occur in men. The biggest one being oropharyngeal or throat cancer, but also anal and penile cancer. And in the US, actually, oropharyngeal cancer in men has now surpassed cervical cancer in women. So more than ever, it's really important to vaccinate our boys. The other reason to vaccinate boys as well as girls is it creates this herd immunity. And essentially what that means is that if more people are vaccinated, there's just less virus around. So we have less HPV to be passed from one person to another. And then the reason to vaccinate the boys is that the boys give HPV to the girls and the girls give HPV to the boys. So we should just vaccinate everybody. Does the vaccine work? So we now have 14 years of it being commercially available, plus many, many years of study before that, and it works. It's actually one of our most effective vaccines. It's not a live vaccine, so it has very, very few side effects, but it works really, really well. So we have studies in the US that show that our rates are going down of precancerous lesions, but the country that has really knocked this out of the park is Australia. So Australia introduced the vaccine in 2007. They started just with girls, with teenage girls, and it was a school-based program. And what that means is that the kids get vaccinated at school. They have a vaccine day, the nurse comes, vaccinates all the kids in the class. When they're due for their second dose at 6 months, they again vaccinate everybody. So they then expanded, the Australian government expanded this program to include boys in 2013. And what they've seen is a 77% reduction in HPV infections. And again, we know this is the cause of cervical cancer and these other cancers. So, you know, we're starting to see the decreases in both the pre-cancers and the cancers. It's estimated by 2028 that Australia will have less than 4 cases per 100,000 women. And by 2066, it's believed that they will essentially eliminate cervical cancer in their country. This was featured in the New York Times. This is Dr. Ian Fraser. He's one of the co-developers of the vaccine, along with a group at the at the NIH in the US. But you know, this Dr. Fraser is a true rock star, you know, really eliminating these diseases in Australia. And he does a lot of advocacy work with governments and groups around the world, trying to convince them to sort of follow Australia's lead related to HPV vaccination and cancer prevention. And it's been interesting now in the era of COVID to see how Australia has the response that they have had to controlling the pandemic. So the goal for vaccination rates for countries is 80%. So you can, when you see this, we're not doing so well compared to other, you know, similarly resourced countries. So we are vaccinating just over 50% of our kids. If you start from the right and look at Australia, they're 75% to 80%. Denmark, Portugal, Belgium, UK, a lot of the European countries have instituted good school-based vaccination programs. So they will all, in the coming years, see far lower rates of cervical cancer and other HPV-related cancers than we do. A country that is really done an amazing job is Rwanda, a very small country in Africa that had a terrible genocide in the 90s. They have or had a very, very strong minister of health, a woman who decided that no girl in Rwanda was going to continue to die of cervical cancer, which was the #1 cancer among women there. And she put together a very strong public health program through HPV vaccination and then cervical cancer screening. And they really have led the world in how to do this and how to do this well. So Rwanda may be close to Australia in being one of the first countries to eliminate this disease. So why are HPV vaccination rates so low in the US? Unfortunately, the HPV vaccine was really politicized when it came out by its association with sex. As I said, HPV is a sexually transmitted infection. Almost everyone gets it. And so when the vaccine came out, the message somehow got lost that it was a cancer prevention vaccine and was associated with sex. And both of those are true. But there's a false belief that if we give our kids this vaccine, that it condones sex. This has been disproven in study after study that kids who get HPV vaccine are not more likely to have sex at a young age. There are also many concerns over safety and, obviously a very strong anti-vaccine movement in this country. The vaccine's been shown to be extremely, extremely safe. It's not required for school entry in most states. So unlike, rubella, meningitis, and the different vaccines that are required by schools, HPV has not been a mandated vaccine. And I think a lot of it is also that we don't have school-based vaccination programs in this country. In Canada and Australia, in many other places, how it works is when your child is due for their vaccines, and certainly for the HPV vaccine, as I said, they just have a vaccine day, the nurses give them, the parents can opt out, but everything's done at school. So, over the years, I know my kids have missed vaccines due to, different things. Life happens, you can't get your kids to the pediatrician, you forget, but also just many, many people just don't have the resources to get their kids to the pediatrician to get their vaccinations on time. So I said it's extremely safe. In 2014, 200 million doses had been administered worldwide. Now it's obviously much, much more than that. The biggest side effects from it are the same as any injection or vaccine: headache, fatigue, dizziness. They did see an increased rate of syncopal events. So girls, especially when they started, girls and boys passing out when they got the vaccine at school. It was unclear exactly what the reason was, other than getting a bunch of teenagers together and having a vaccination day. But there were some increased reports of kids fainting when they got the vaccine, but very, very low. I think what's most important is that there's no increased risk of Guillain-Barré syndrome, multiple sclerosis, or other neurologic diseases. There were a lot of sort of one-off and social media stories about the vaccine, and still are when it came out. And you'll see those if you Google it. But there have been study after study in JAMA, the New England Journal of Medicine, all very, very well done scientific studies, many of them in Scandinavia with thousands and thousands of people. And there is not any increased risk of any of these diseases associated with HPV vaccine. So how are we doing in the US? You can see here a map of the US. The light blue are the states doing the worst. So you can see Texas falls there. That's where we are vaccinating 30 to 39% And this is just of our girls, not the boys as well. Those rates now, at this time in 2016, the US average was 49.5. We're now just over 50%. The states in orange or red are the ones with the highest vaccination rates. So you can see a lot in the Northeast, Maine, Massachusetts, Rhode Island, New York, also North Dakota, Washington, DC, and those are the areas that have the highest rates of vaccination. So there was a big concern by the Texas government about how poorly we were doing in our state. And you can see here that we're 47th of the 50 states in our HPV vaccination rates. And if you look at the Tdap, which is, you know, other vaccines that you get around the same age, we're doing okay there. So it's really the HPV vaccine that has been low. Rhode Island has the highest rates. They actually mandated it for school. Parents are able to opt out, but it's one of the required vaccines for school probably about 2 years ago now. And that really helped boost their rates, as well as a lot of community education about the HPV vaccine. If you look within Texas, it's interesting. Dallas actually has the worst rates. Houston falls in the middle. But Dallas has very, very low rates. And interestingly, El Paso has some of the best rates in the country. And that, again, is believed to be attributed to a lot of very good community education, parent education, pediatrician education. So you can see here some information from the CDC. They, again, have been trying to have a very good, you know, public campaign to get people to understand the HPV vaccine. So the first one says you're not opening the door to sex, you're closing the door to cancer. And the other one says if there were a vaccine against cancer, wouldn't you get it for your kids? And again, HPV vaccine is cancer prevention. So what about school-based vaccination? So when I first came to Texas, we talked a lot about trying to do, with the rates were so low here, we talked about trying to do school-based vaccination, which has obviously been successful in all the other countries I mentioned. It's not something that we commonly do in the schools, and certainly not something that the Texas school boards were excited about talking about HPV or bringing HPV vaccination into the schools. Our group does a lot of work on the Texas-Mexico border, so down in the Rio Grande Valley, or RGV. This is a region of our state, has a population of about 1.3 million. 90% of the population is Hispanic. It's a very underserved population, with 40% living below the poverty line. And less than 10% of women are actually getting screened for cervical cancer. They have lower numbers of doctors and nurses, nurse practitioners, and PAs than the rest of the state. And I started working down there several years ago because they have very, very high rates of cervical cancer. So their rates are about 30% higher compared with the rest of the state of Texas. And we have high rates as a state. So this is a very, very sort of a hotspot of cervical cancer. So we started actually a HPV vaccination program there in the schools. It's a collaborative effort between UTMB in Galveston, UTRGV that's located in McAllen, our institution, and then the UT School of Public Health. And we were able to partner with the Rio Grande City School District, which is a small city along the border, and with their Parent-Teacher Association. But we talked with them about the really high rates of cervical cancer in the region and some of the things we could do to prevent it. A very, very forward-thinking school superintendent and principals, and they decided that they would let us give it a try and to do the vaccinations on site at school. So we started in 2017, and we essentially went to it wasn't really the first day of school. They have a day prior to the first day of school where the kids come with the parents to pick up their schedules, make sure they have all their enrollment forms done, you know, et cetera. So we just set up a table most of the folks in my group speak Spanish. And so we just, had education from MD Anderson about the vaccine and about cervical cancer. The kids that day had to bring their immunization records so we could see if they had been immunized by their pediatrician for HPV, and very few had. So we offered them right then and there if they wanted to get their child vaccinated. We didn't quite know what to expect, but on our first day, we actually vaccinated 98 middle school kids. And then 6 months later, we were back and did the second vaccination. And then the program has since grown. I mean, this was 3 years ago. And now it's open at multiple schools in the area. We had a lot of help from the parent-teacher organization there, an association. We did a lot of sort of lectures like this with them and explained everything for them. And then they had a very, very active Facebook group for the school and really promoted this. So it's sort of had the opposite effect of a lot of the anti-vaccine groups that are out there, but instead this was really great for these folks to encourage one another to vaccinate their children against HPV. So now we have more than 3,000 kids in that, in that school district, in that city that have been vaccinated. And I say they're going to be like the Rwanda or Australia of Texas, where we'll go from a region that had some of the highest rates of cervical cancer to hopefully having very, very low rates. So part of this was I really want to show that it's possible to do school-based vaccination in the US and in Texas, which most people would say that is not possible, but I think it is. It just takes very forward-thinking school administrators and parent groups. I just wanted to talk for a couple of minutes about cervical cancer and some of the work that we're doing related to that. But again, I just really want to emphasize that cervical cancer is preventable. We know that it's caused by HPV. This is a picture of Dr. Harold Zerhausen, who actually won the Nobel Prize in 2008 for making this discovery. So it really is incredible that we know the cause of one of the cancers that we treat and that we actually have a vaccine that prevents it. And for people who are oncologists like me, this is just incredible, right? That we have a cancer that we can totally prevent. So, the vaccine obviously was not available when most of us were kids, but we have really good screening tests for cervical cancer. So most women will have had a Pap test, and now we actually can do HPV testing as well. So most of the time now we do a combination of Pap tests and HPV testing, but we have really, really good screening. If those tests come back abnormal, then women need to come back for a test called colposcopy, where we look at their cervix with a microscope, do biopsies, and find the cancer cells before they're cancerous, so essentially pre-cancer. And then we can treat it. We do relatively simple procedures to treat it. Some of them we can do right in the office. And the important thing is it takes about 10 years to progress from an abnormal Pap or a positive HPV test to actually getting cancer. So we also have a long, long time to actually treat this. So no woman should die of cervical cancer with what we know today. But unfortunately, we have more than 500,000 new cases and 260,000 deaths annually worldwide. What you can see on this map is the countries that are in the very dark red or maroon are the ones with the highest rates of cervical cancer. So primarily in sub-Saharan Africa, Latin America, and Central America. And then, as I said, in the US, our rates overall are very low because women have access to getting a Pap test and screening, but there are certain, pockets of the US, like the Rio Grande Valley, where the rates are very, very high. And most of that is due to a lack of screening. As I said, 80% of people get HPV, so it's not that they get more HPV, it's just that they can't get screened and treated when they have precancerous lesions. The WHO, the World Health Organization, has made a call to action to eliminate cervical cancer worldwide or globally. And they've set very, very strong targets with 90% of girls around the world being vaccinated. So we're nowhere near that in the US. You know, as I said, we're just over 50%. The worldwide goal is actually 90%. And then that 70% of women get screened with an HPV test or similar, you know, in the US, we can use Pap tests as well. And then very importantly is that 90% of those women who have an abnormal test actually get to someone to get the care they need to get treated for the precancerous cells. You know, in my practice at MD Anderson, and I also work at LBJ, our county hospital, every time I see a woman with advanced cervical cancer, which is, you know, usually every week, you know, I'll ask them about if they've ever had screening. And most women in the US have had screening at some point. They had a Pap and it was abnormal, but they either didn't have insurance or access or were scared and didn't go for all those next steps, and they were asymptomatic. And then by the time they were seen again, they had bleeding or other problems and were found to have cancer. So I think it's a really important part of the systems that we set up that we're able to get these women back in when they have abnormal screening tests. People often ask, why do we even need screening anymore? Because we have this great vaccine. And the reason is that our vaccination rates are not very good. So our kids, you know, our daughters will need to be screened in the future. And then also the vaccines don't treat infections that people already had. So for everyone who was too old to get the vaccine when it came out, you know, we essentially have 2 to 3 generations of women who are still at risk because they couldn't be vaccinated. So we think that screening will be necessary for the foreseeable future. As I said, in the US, how the cervical cancer prevention works, or in the US, Europe, any other high-income country, is that women come and get screened for cervical cancer with a Pap test and or HPV test now. If that's abnormal, as I said, they come back for the colposcopy and cervical biopsies. And then if they have precancerous lesions, we can treat them, where we actually remove or burn or freeze those precancerous cells. This works really well in the US. We've decreased our cervical cancer rates by probably 60% since the 1950s. Cervix cancer used to be really, really common. Now it's not, although abnormal Paps and precancerous lesions are common. But the good news is we're catching them early and treating them. But the systems worked really well here, but not in all those countries that were that dark red or maroon color. And the reason is they just don't have the lab set up, or the gynecologists or doctors, nurses, et cetera, and infrastructure to be able to do this screening. So a lot of the work I do is in those countries that have very, very high rates or along the border to try and simplify this whole process for women. Because if you look at even the availability of a pathologist to look at all those Paps and biopsies, it's just not feasible. This is a map of Africa that shows, you know, in many countries you have 1 pathologist per, you know, 5 million people or 2 million people, versus in the US we have 1 pathologist per 19,000 people. I mean, at MD Anderson alone, just in the GYN oncology department, we have 6 pathologists. That's more than some of these countries have. So I do a lot of work with Rice University. This is Dr. Rebecca Richards-Cordum, who is an amazing colleague and friend and collaborator. But she runs a program at Rice with engineering students and faculty to try to develop low-cost solutions for some of these healthcare problems, and specifically cancer screening problems around the world. So she's developed an HPV test that can essentially replace the Pap and our existing HPV tests. All of those things here cost $100 to $200, and she's developed one for less than $2, where you don't need a lab, you don't need equipment, it takes less than an hour. And it's essentially like a pregnancy test, like we would buy at CVS or Walgreens. And what we're working towards is that women would be able to screen themselves in the same way. We used to have to go to the doctor to get a pregnancy test, and it used to be a blood test, and then the urine test became available, and then they became available for anyone to buy over the counter. And we're working towards being able to do that with HPV as well for cervical cancer screening, and for women to be able to sort of do their own swab of the vagina at home, and either mail it in or ideally even be able to run the test themselves at home. So this is sort of the future, to be able to do self-sampling and not have to go to the doctor to have an exam. Rebecca also does a lot of developing technologies that we can use instead of having to do colposcopy and biopsies. And again, this is a picture of one of her students who's about to graduate from medical school, Sonia Para, and Paul, who's a PA who works on one of the mobile vans that are along the border doing care for families there who don't have insurance. We've run big studies in Brazil. You can see this is one of our mobile vans there that travels all around Brazil to sort of take the screening and treatment to the women instead of having the women travel to us. We do a lot of training and education as well. We can develop all the tools we want, but if we don't have anyone who knows how to use them, we won't be helping. You can see here we've been using Zoom long before COVID to help train and educate our partners all over Texas and all over the world while we can still be at MD Anderson. We also, pre-COVID, spent a lot of time traveling to do hands-on training and see patients with our colleagues. So in summary, cervical cancer is preventable. The HPV vaccination is safe and effective, not just for cervical cancer, but also for head and neck cancer and other cancers. We really need to increase our HPV vaccination rates. Texas is ranked 47 in the US. And then I think it's important to remember that 85% of cervical cancer cases and related deaths occur in low and middle income countries, but also in low resource settings in the US and just among women who don't have access to screening and preventive care. And then we're working hard with RICE to develop new screening and diagnostic techniques. And I'll just end with a picture of my two kids. And to say that please vaccinate your kids against HPV so we can prevent all of them from becoming our next generation of cancer patients. I'll end there. Thank you.
Wow, thank you so much for that presentation. I feel like I knew a lot about HPV, but there was some stuff that I learned. So I'm really grateful that you're here for that, to provide us with that information. So we're going to go ahead and jump into some questions now. The first question is, can I still give my daughter, who is 17 and not sexually active, the vaccine?
Yes, absolutely. And now is a great time to do it. It's recommended up to age 26. And as I said, even the FDA approved it up to 45. But yes, if she's 17, she'll need three doses of it, but absolutely, I would go ahead and give it to her.
Okay. The next question is, at what age should girls start getting pap smears?
So in the US, the recommendation is 21. So even if they're sexually active before that, we don't recommend screening for cervical cancer because the rates are really low. Are essentially non-existent. Most countries have gone to age 25, and I imagine that we may eventually do that in the US. That causes a lot of panic among people because they think we're gonna miss something, but it's actually the opposite. What we've found is that when we screen young women, they tend to get HPV and then clear it. So if we screen them when they're young and we're catching all these abnormal cells and HPV that they were just going to clear on their own, we treat it because now we know that there's something there, when in fact we're treating people who would never have had a problem. What we know is that if the HPV persists into your 30s, then you're the group at risk. So with HPV testing, we actually definitely don't do that before 25 or 30. And people say, well, why not? And we say, we assume everyone's positive. 80% of people are positive and they'll clear it. So just leave them alone and then start screening later to be sure. So the recommendation right now is a PAP starting at age 21. And it's every 3 years, not every year anymore. So it's a PAP from 21 to 30. And then once you turn 30, it's a PAP and HPV. And then if those are negative, it's actually every 5 years. So we've really changed the guidelines, and people worry that you're going to fall through the cracks, but you won't, especially with the HPV testing being so good.
That's really good to know. The next question is HPV and the cervical cancer link. Are there other cancers where this is a definitive link to a virus? This link in virus causation feels novel to me, and I wonder about what we will eventually discover about COVID-19. But I guess the question here is, are you aware of any other definitive link to a virus?
Yeah, so there are a few other virally mediated cancers caused by viruses. And one of them, sorry, my dog just walked in, it's super loud. The hepatitis B and hepatitis C are also linked to liver cancer. So that's the biggest one. And then Epstein-Barr virus, especially in Africa, is associated with some nasopharyngeal cancers. So HPV with, cervix, oropharyngeal or throat cancer, anal, penile, vulvar, vaginal cancer. And then the other really big one is the hepatitis B and hepatitis C with liver cancer.
Thank you.
And as far as we know, COVID is not associated with any cancers, but, there's so much we don't know about COVID yet and the long-term effects of it.
Great. Okay, so the next question is, if someone is infected with one type of HPV and their immune system clears it, are they immune to other types of HPV? It's
a great question. We think for some of them, there's what we call some cross-reactivity or like overlap, that they're very similar. And so the HPV vaccine we have now covers 9 types of HPV. The one that originally came out covered 4, so now we've added 5 more. But even there's like hundreds of types of HPV, but those are the main cancer-causing ones. But what we know is that it also has some cross-reaction with the other types that will do that. And most of the time when people get HPV, they don't just get one type, they're infected with multiple types at the same time, but it may not always be the same types. So that's the argument for giving the vaccine after someone's already sexually active, is they might have been exposed to type 16, but not type 18. And it's really hard to know because your body clears it. So even if you don't have an active 18 infection, then you may have the year before or 5 years before. And because the vaccine doesn't have any significant side effects, there's sort of not really any downside. So we recommend that people, if they didn't get vaccinated before they were sexually active, that it's still okay to get vaccinated. But the ideal is to vaccinate our kids before they're sexually active. That gives you the best protection. The other thing is when the kids are that young, their immune response is much, much better. So we think they're even better protected than if you get vaccinated when you're in your 20s or later.
Okay, well, yeah. Another question that popped up was, is the vaccine more effective if you wait? I know that you mentioned having the vaccine before you're sexually active, but even if an individual is older before they become sexually active, is that you're saying the vaccine is going to be more effective when given at a younger age?
And definitely more effective before, we say HPV naive, where you've never seen HPV. And the classic thing that used to happen, hopefully less so now, is people would go to the pediatrician and they'd say, okay, your kid needs an MMR, a Tdap, all these vaccines. Oh, and we can do HPV, but it's not required. And then people would say, well, what's HPV? Oh, it's a sexually transmitted infection. And you're sitting there with your 12-year-old and you're like, oh, no, I don't want to talk about we'll just do it later. And then unfortunately we missed that window. And the pediatrician, I mean, they're super busy, running their offices. The kids have lots of problems that sort of just kind of gets missed. And the other thing is, with the flu, you'll get it that year. With cancer, you're not going to get it for 30 years. So it's hard to kind of think that far ahead. And so unfortunately in this country, it just, we don't have very strong public health systems, as we can all see now with COVID, that, we just have terrible rates. When I work in other countries, like in Latin America, and they'll say to me, if you guys don't want that vaccine, please give it to us. We would do anything to be able to have free HPV vaccination for our kids.
Right, I believe you. Okay, so the next question is, you mentioned that school-based vaccination programs would help in ensuring the vaccine is accessible and reducing cancers related to HPV. What can we do in general to push a school-based vaccine program here in Texas? Are there any forward-thinking people in districts in the Houston area that you know of?
Yeah, I haven't tried lately in the Houston area. It's a good question, and I think that I think it would be worth revisiting. I think COVID has turned all our lives upside down, and it's going to be interesting to see how we, once a vaccine is available, how we approach this and how people get it. And certainly how underserved communities get it. I mean, that's what I worry most about, right? I mean, even for high income regions, even if the kids don't get vaccinated, they'll probably have access to screening, right? They'll probably have a doctor, they'll probably get a pap test. So it's less of an issue there. But I don't know any. I mean, I think it would be great to, we originally thought about approaching KIPP or some of the schools that maybe, a little bit thinking more outside the box. I think school nurses are a great way to approach it, and parent teachers and superintendents. Most of the places, even in the Valley, the first 2 school districts we went to didn't want to talk to us at all. I mean, they just had too many other things going on, and this was a controversy they didn't want to take on. But Rio Grande City, I mean, really, really impressed. And now there's almost a competition between the schools to see who can vaccinate more of their kids.
That's awesome. This next question is, how do we encourage parents of boys to get the vaccine?
I think if anyone knows anyone who's had oropharyngeal or throat cancer and watch, it's usually men in their 50s, 60s, and watch the treatment they have to go through with radiation and chemo, I think that's always a strong way. But I think also, I think reminding them that their boys can get cancer. I mean, I think if we just say it's a cancer prevention vaccine, that's a good way. But oropharyngeal cancer is really a tough treatment to go through, and unfortunately, a lot of people die of it.
Kathleen, I'm so sorry to jump in, but my dad is an oncologist who had HPV, throat cancer, and he worked in AIDS for many, many years. Brutal treatment, but thankfully he was a bit overweight when he started. So he ended up very fit when he was done. I said, Daddy, you're the only person that looks good after this. It was a brutal year. So I can speak to that. And when I talk to him, and the only reason I'm bringing this up is for the parents who worry about the sex aspect of politicizing. I was talking to my dad about AIDS prevention, talking to your kids about condoms. And Meredith will tell you I'm the worst. I don't want to talk about it. But my dad said, when you get on a plane, the first thing they tell you is what to do in case of an accident. So you talking to your kids about a condom isn't saying that you don't want them to go out and have sex. They're not going, you don't want a plane accident. You don't want a plane to crash, but they talk about it. So anyways, throat cancer is horrible. Vaccinate your boys. I can attest for it.
And back to the question about when do kids or when do young people need to start getting PAPs, and it's 21. But what I will say is it's really important for your kids to get access to birth control. You know, HPV vaccine we can give, and then I can't emphasize that enough. I don't do obstetrics anymore, but I delivered babies for a number of years, and I have delivered countless 12, 13, 14-year-old girls having babies. So it happens, and it happens to rich people, poor people, all ethnicities. So, you know, I can't emphasize the need for sex ed and birth control.
So the next question is, what does it mean when people say an HPV infection cleared? Is the infection gone or is it dormant? And can it still be spread to someone else?
Yeah, it's a great question. So when it's cleared, it means when we do an HPV test that that it's negative. Now the tests, like the COVID tests, are not 100%. But most people's immune system will just clear the infection. In some people, they may get reinfected with different types, so that could be a new infection. And we also think that in some people it may stay dormant and then become reactivated. You know, I work at a cancer hospital, so I see a lot of women with breast cancer and other cancers who have had normal PAPs for years, and then all of a sudden have an abnormal PAP when they're immunosuppressed from their chemo. And we don't know if it's a new infection or a reactivation of an old infection. But the important thing is when people are HPV positive in their 30s, 40s, 50s, and it's persisted, that they're the ones who could be at risk for these precancers that we can treat to prevent them from becoming cancer.
Okay. And the last question that I have is, I received 2 doses of the HPV vaccine but missed my 3rd dose. Do I need to start again?
No, that's a great question, and you don't. No matter how long it's been, we just give that additional dose, and that's both for adults and kids as well.
Okay, great. Well, thank you so much for your time, taking time to answer these questions. We had some really great questions, and I'm going to go ahead and share my screen one last time. Okay. So if you do think of any additional questions after we end this meeting today, you can feel free to send those to healtheducator@thewomensfund.org, and we will be in contact with you to get you an answer to your question. We also ask that you please take a few moments of your time to complete our survey and let us know what you thought about today's presentation. Give us some feedback, let us know what you're interested in hearing. We are really looking for some feedback, and so if you do take this survey for us, you will be entered into a contest to win a $25 gift card. So make sure you take this survey. I'll be sending the link out as well in a follow-up email following the presentation.